One of our last blocks in cardiology is a review of endocarditis that we covered at least briefly in the infectious disease block. We'll review some of the data we looked at earlier in regard to common things we think about when we have a patient with bacterial endocarditis. And usually when we see these patients in practice, one of the highest risk factors, at least in the Northeast we see, are folks who are active IV drug abusers who get contaminated during injection and then end up with a valvular vegetation. Another infection that we think of with the risks associated with long-term therapy is endocarditis. This infection in the heart valves or other endocardial tissue where there might be vegetation on those valves. There's a platelet fibrin complex that becomes infected with microorganisms, bloodborne or otherwise. And the risk factors for developing endocarditis are a combination of some valvular predisposition. Maybe someone has a mitral valve prolapse, they have prosthetic valves, they have some other valvular disease, particularly valvular disease in combination with IV drug abuse, where the bloodstream gets seeded with a bacteria because of IV drug abuse. And the incidence is historically, 3 or 4 cases per 100,000 people per year. I will tell you, though, that most cases of endocarditis that we're seeing now in our hospitals is related to IV drug abuse. And we're seeing it much more commonly, and it's becoming really quite problematic because on top of all the other risk factors that IV drug abuse pose to a patient, the endocarditis risk is that is becoming quite dramatic. And what you may end up with is not only do we have to treat it aggressively with antibiotics, but the infection itself can lead to valvular changes that require valve replacement or other interventions for serious cardiac valve disease. And the patient may also have reduced cardiac output because of that. And so lots of complications with endocarditis. And unfortunately, our current IV drug abuse epidemic is contributing to much higher rates of endocarditis than what we're seeing at least regionally in New England. The presentation of endocarditis varies. Sometimes you'll present with a low-grade fever, with remittent fevers. And about half of patients, you might see cutaneous manifestations, petechiae, genuine lesions, or splinter hemorrhages. Classically, in this image, you can sort of see the fingernail bed is a sort of a flooding of that into these valvular vegetation sort of become tiny emboli that then get lodged throughout the body and include these classic splinter hemorrhages you see on fingernails on physical exam. The majority of patients who have endocarditis will present with a cardiac murmur. They often may have also joint pain, myalgias, low back pain, arthritis. That could also be the seeding of these vegetations throughout the body. They present often with fatigue, anorexia, sort of vague complaints, weight loss, night sweats. They may have a normochromic and normocytic anemia. They usually have an elevated white count, increased sed rate or C-reactive protein. And blood cultures are usually positive in the majority of patients. And so part of the workup here, particularly someone with a history of IV drug abuse, that you hear cardiac murmurs, that other factors here that lead you to think endocarditis, then you're going to get blood cultures right at the get-go and get a number of them. Endocarditis pathogens, they vary, and you'll see strep is a common one, Staph aureus, and Enterococci. You'll see, though, the pathogens are going to vary based on whether or not the patient has a history of IV drug abuse. And so here's some classic causative organisms for endocarditis pathogens, but they can really vary based on the patient. But in most cases, about half of them are strep, and strep usually is responsive to some of the more narrow spectrum beta-lactam antibiotics. And so that blood culture is really going to help us determine and guide our ongoing intervention or ongoing therapy. Complications with endocarditis, we've alluded to this already, is reduced cardiac output with heart failure. risk for emboli, also a risk for a mycotic aneurysm as well. And we need to get lots of blood cultures. We alluded to that. 3 to 5. Typically what we see is 4, but sort of err on the side of as many as you can get, drawn at different sites within the first 12 to 24 hours and repeated accordingly. So blood cultures are really, as soon as you suspect endocarditis, ideally before you start antibiotics, you want to get all those cultures. The treatment of endocarditis depends on what the pathogen is. Typically, this is going to be guided by your blood cultures. And then narrow spectrum beta lactams like PEN-G, maybe with synergy with an aminoglycoside like gentamicin for a couple of weeks, are pretty common, depending on whether we're talking about a native or a prosthetic valve. Prosthetic valves need longer durations of therapy, and depending on what the pathogen is, we are looking at longer durations of therapy as well. More sort of table information here about our treatment based on pathogens, but again, we typically see we'll add for MRSA when MRSA is a question or enterococci is a question, which is less common. We're going to add often vancomycin to our picture. We also need to think about patients who have had a history of endocarditis or who are at risk for future endocarditis, whether or not they need prophylaxis. And so patients for whom we're going to prophylax for prior to dental procedures, prior to any procedure where they could have a small window of time where they have particularly these gram-positive pathogens in the bloodstream, during dental procedures, we're going to look at folks who have had valvular issues in the past. They've had prosthetic cardiac valves. They've had a history of endocarditis. They have congenital heart disease. They have a repaired congenital heart defect at some point, or they've had a cardiac transplant. All of those are folks where we're going to always give prophylaxis prior to dental procedures or any other manipulation or procedure that's going to be associated with a risk for transient exposure of these pathogens in the bloodstream that could then lodge on these heart valves. Let's look at some of the prophylactic treatments for these patients who are at risk for future endocarditis, particularly around dental procedures or other. The standard classic dose to give is amoxicillin, 2 grams for an adult, an hour before the procedure, or in children, 50 milligram per kilogram dosing. And that's pretty typical for most folks who don't have a true panallergic status. For those allergic to penicillin, then clindamycin is probably our next choice, or cephalexin if they don't have a type 1 hypersensitivity. Sort of in the background, sometimes folks will use azithromycin or clarithromycin, but most clinicians sort of reserve that for cases where amoxicillin is not appropriate.